kidney support system. Previously, we used to call it renal replacement therapy. So, KST. It is the when you will give your dialysis to a patient, maintenance dialysis to a patient. So, what are the indications of dialysis? To start with in is AKI and possibly in other renal impairment, kidney chronic. So, when fluid overload is more than 10%, more than 20% is obviously made more dangerous to wait. And when patient's edema has diuretic resistance, pulmonary edema is there, you should go for dialysis, at least in a more importantly in an oligonucleotic child. And when the child has difficult symptoms like uremic encephalopathy, pancreatitis, pericarditis, and bleeding, you should go for dialysis. Refractory hyperkalemia or hyponatremia, not controlled by the your medical or conservative way, so that should be dialyzed. Metabolic acidosis with sodium bicarbonate giving at times is not wise because of the edema, hypertension. The patient may have the bad consequences, so they have to be dialyzed, preferably hyponatremia, and also refractory hypertension. At times, they relieve by dialysis. So, apart from that, when you have toxins, dialyzable toxins like salicylates, alcohol, and others, and when there is inborn error metabolism with renal impairment, when or without even when you have hyperammonemia, you will be benefited by dialyzing a child. So these are the points when you should start the kidney support therapy. And the modalities of dialysis are three basically, and then the intermittent hemodialysis. By far the commonest good one, rapid clearance is there, and your vascular access is needed in those cases. And this child also need anticoagulation and water treatment plant and facility. They have at times in the overzealous dialysis hypotension and your large fluctuations. So keeping in this, but the clearance is good. Thereby, you should have this one modality. And PD, peritoneal dialysis, little bit slow clearance, but have small subset of patients. You need to do it. Catheter blockage is possible. Peritonitis is possible. Protein loss 0.4 gram per kg per day is also possible. So initially this IPD, intermittent peritoneal dialysis, was the practice. You give it for a few days, 3 to 4 days, 5 days. At times you can give longer. So and then CKRT, continuous slow continuous clearance, you have over here, useful in hemodynamically unstable patients. Your in the labor intensive places, expensive. Instrumental cost and the facility cost is very high, but it is an effective treatment in a subset of patients where you need slow continuous your dialysis. Finally, you have the prolonged intermittent kidney replacement therapy. Here you have rapid clearance, your urgent clearance. You have accurate ultrafiltration in the you are having the to be done in an hemodialysis facility. It's less expensive, but vascular access and anticoagulation are needed, and your complications and as usual possible in like other hemodialysis, in those cases.